relate there?
Yeah.
Okay. I will freeze that, then show the machine, because if I show that, that will become much delayed.
Yeah, already it is. Patients are a little agitated. Adult only the influence, that's kind of. Okay. Settle to the patient. Would you like to talk anything to the patient? Or like
Oh, yeah. That's a child, is it?
Yeah.
Okay. Yeah. Hi.
छान.
सर आहे
हा दिसते हा नाही मग असं एकदा ते दाखवा तुम्ही ते थोडंसं मी सांगू ना
अरे हे मध्ये येते.
अँगल थोडंसं हे करा.
Which class are you? कौन सा क्लास में है?
फाइव स्टैंडर्ड
कौन सा स्कूल गुजरा है?
ZP
हॉलीडेज अभी? किधर जा रहे हैं हॉलीडेज को?
हॉलीडे तो अभी थोड़ा
भूल गया. कब राव उधर से आओ.
बसवा
मास्क काढलं. मास्क याचा
इधर से. What's your name? मनस्विनी. क्या मीनिंग क्या है मनस्विनी का?
हिंदी कळतं ना तुला? हिंदी कळतं?
हैं? मनस्विनी नाम का मीनिंग क्या है? हैं? You don't know the meaning? Yeah. I will.
थोडं पूर्वी गुड जॉब.
Now I'll check your teeth. Is it okay? Huh? Okay. Oh, boom. आकर बेटा. Very good job. Very good. What need to be done?
Extractions.
Of?
7-4.
Extraction of
7-4 months.
Okay.
Is it over it?
Can you take the shell? Can you take the backrest down? So since the child is been waiting for a long time, it may not be fair for me to demonstrate all the parts before I do the procedure. I can explain the whole thing after I do the procedure. So I just wanted to finish the procedure as early as possible so that the child can go home without cursing us. Akar beta, can you switch on the light?
Yes. It's here.
Yeah, good job. Akar beta. Very good. So if you look at the, no, we don't need monitoring of BP for any even adults also. Electronic, it's already there. Electronic monitoring is not needed for nitrous oxide inhalation sedation. So what we are trying to see is, first I said we are going to fix the nasal hood. If you see the nasal hood, there is no obvious, बंद कर बेटा, मैं बोलते जब खोलो, okay? Done? Done?
Done.
जोर से बोल,
Done.
जोर से,
Done.
और जोर से, जोर से बोलो, चिल्ला के बोलो.
Done.
अरे सुनाने दे रहे मेरे को. So if you see the nasal hood, it is balanced equally, and nasal hood is actually resting on the skin. It is not very tightly placed, and this is not a hermetic seal, as I said. Not having hermetic seal itself is a protection in the nitrous oxide. When there is some kind of time where if you have any hypoxia, you thrive and you move the you move the head. When you move the head, automatically the air is going to enter. So this is an inherent safety mechanism by not having the nasal hood tightly placed on it. But no doubt you simply have to snugly keep it there, so that there is not going to be any obvious leak where the room air is going to get into the nasal hood and she will be breathing. The plan is to do a dental extraction for her, and I am going to give nitrous oxide to about 40, something like that, so that I will take her just to about plane 3 and bring her back to plane 2, because plane 2 is where I have to give anxiety relief, and I have a purpose of giving local anesthesia. So I take it to the end of plane 2 or starting of plane 3, give local anesthesia, which is vestibular injections, and then come back. ये आपका अभी सांस ले रहे ना आप, नाक से ही लेना. ओके, डन.
Done.
प्रसाद इंक्रीज करो. Flow is fine. Flow is fine. I said the flow need to be adjusted. I am not trying to explain all the things at this point of time. I will do it during the demonstration. I will just try to finish the procedure now, so that you will understand how the child is going to be less apprehensive and how she is not going to react to any kind of noxious stimuli under influence of nitrous oxide. Put it to 20. Prasad?
Prasad.
Yeah, I'll do that. 1 second. So I am trying to increase nitrous oxide by increments of 10% and wait for about a minute's time. And during plane 1 I am going to increase 10s and wait for a minute time. In plane 2 I am going to increase by 10s and wait for 3 minutes time. So this fulfills the ramping up. So ramping up, slowly increase the nitrous oxide over a period of time, not take you there immediately. Okay, this is called a nasal hood. I am going to explain the parts of it little later. You just have to observe how the procedure is going on, because the child has been waiting for a long time for the procedure. So I thought I will finish the procedure, then do the demonstration a little later. मूवीज देखते आप? कौन सा मूवी देखा लास्ट? याद नहीं आ रहे? कार्टून्स देखते?
हाँ.
क्या आपका फेवरेट कार्टून है? मेरा फेवरेट क्या है मालूम? गेस करो. पी तो स्टार्ट होता, पी से स्टार्ट होता. हाँ, 2 वर्ड का है वो. सो माई कॉन्वर्सेशन इज एक्चुअली डाइवर्टिंग अर अटेंशन फ्रॉम द सेडेशन. 2 वर्ड का कार्टून है वो, दोनों वर्ड्स पी से शुरू होता. वो एनिमल का कहानी है, सब बच्चों लाइक करते, चैनल में आता. पूछो किसी को मालूम है क्या? हाँ, सी एवरीबडी इज टेलिंग पप्पी. वो मेरा फेवरेट है. दूसरा फेवरेट क्या है मालूम? बालू का क्या है?
क्या?
एक बच्ची रहता, एक बेर रहता. अरे wait, I didn't ask you. Huh? So when I say my communication with my sedationist is, when I say this, they are going to increase 10% and wait for my instruction. There is not going to be any other communication. When I say this, You are going to increase 10% rate. Huh? Okay. I will ask you third question. मेरा तीसरा मोस्ट फेवरेट है. उनमें भी 2 एनिमल्स रहता, नॉटी एनिमल्स. इसमें एक बहुत नॉटी, दोनों नॉटी है. इसमें एक तो कैट रहता, दूसरा माउस रहता. नाम बोलो बस. नो क्लूज, नो क्लूज, नो क्लूज. कैन यू टेक द बैक रेस्ट डाउन? अरे बहुत पुराना ये. बैक रेस्ट डाउन, बैक रेस्ट डाउन. इट डज नॉट गो, इज इट? ओके. टॉम एंड जेरी. हाँ, वो तीसरा फेवरेट है. देखा कि नहीं?
नहीं,
टॉम एंड जेरी नहीं देखे?
मैं नहीं देखती.
कार्टून्स नहीं देखते, टॉम एंड जेरी नहीं देखते?
टॉम एंड जेरी नहीं देखती.
अरे क्या है जी. कैन यू लोड एंड गेट? और क्या यूट्यूब में क्या देखते?
यूट्यूब हमारा फोन नहीं चलता.
हैं?
हमारा फोन चालू नहीं है.
चालू नहीं रहता या बंद करके दे दिया?
नहीं, बिगड़
अलाउड नहीं है? अलाउड नहीं है?
बिगड़ गया है.
ओ, अगर चांस मिला तो
शॉर्ट्स देखते हैं.
क्या शॉर्ट्स?
कुछ भी लगता है.
जो 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 आता वो देखते रहते.
नहीं,
डांसिंग शॉट देखते या फनी शॉट्स देखते?
फनी.
फनी कौन सा वाला फनी? कौन सा वाला फनी? यस. कौन सा वाला फनी?
जो आता है वो.
अभी आराम हो रहे ना आपको? कैसे लग रहे
ठंडा
हैं? हैं?
ठंडा.
ठंडा ठंडा लग रहे हैं आपको? They will feel little paresthesia of the lips. They will feel little funny on the toes. Just ask her in Marathi whether she feels little funny things on the toes.
वो गुदगुला होता है थोड़ा. हो
किधर किधर हो रहे?
पैरों को.
Ah, see, extremities will start feeling little numb first. So that is the signs what they express. So it's always good to have shoes off. So when they feel the lips and thumbs and toes, they keep moving it. So you know that the effect is happening there. So though we are giving nitrous to about 50, you're not realizing plane 3 here. We are realizing only plane 2. Because I'm making a speak. As we speak, she's actually throwing out nitrous oxide on me. आकरो बेटा, आकरो. वेरी गुड. ऐसा करके इधर तोड़ दबा देते. ओके, डन.
डन.
जोर से बोलो.
डन.
जोर से.
डन.
हाँ, नाक से लो. अच्छा लो सांस. गुड जॉब. आकरो. वेरी गुड. कीप लुकिंग एट द पल्स. It is not increasing or decreasing. That itself tells you that she is not anxious. कैसा है? आराम है? नाक से लो सांस. अच्छा. वेरी गुड. गुड बोले तो थम्स अप करो, बैड बोले तो थम्स डाउन करो. बोलो, गुड और बैड?
गुड असतं मग हात वर करायचा आणि
अंगठा वर करायचा आणि बॅड असेल तर अंगठा खाली करायचा. ठीक आहे.
If you can see her movements now, they're slightly getting now. You see, now what I want you to observe is it slowed down. It took almost 1 minute for her to, I mean, about few seconds for her to realize what we are asking. Usually they should have raised immediately. आकर बेटा जोर से. Very good. Good job. Mukulu. Mukulu. Now the purpose is over. When the purpose is over, I am going to go back to plane 2. So plane 2 is going to be between 25 and 35. So now, right now it is 50. I am going to go to 30. Up, down. This way. 30, 30, 30, 30. More. 30. Now my objective is to achieve only anxiolysis because I have given the local shot. For local shot, I went to almost at the end of plane 2 or the entrance of plane 3. Given local, serve the purpose, then came back to anxiolysis. So you go home is always anxiolysis. टॉम एंड जेरी कभी देखा आप? कभी नहीं देखा टॉम एंड जेरी? टॉम एंड जेरी देखा कि नहीं? इफ यू सी हर रेस्पॉन्स नाउ, इट्स वेरी स्लो.
मनस्विनी तोंड बंद कर.
It might appear as if I am taking lot of time, but when you actually start doing it, since your routine is going to be that way, you can quickly finish. You can do more number of children in a shorter thing because you have systems in place. Moment the child walks in, I know my assistant is going to take care of all these things. I don't have to do all these things. So they know that the child is in plane 2. Then they will call me. Till that time I don't have to be there. I have to arrange all other instruments or I have to plan my treatment. I am not going to be there at all sometimes. So once the child is in plane 2, then I will decide whether I have to bring it to plane 3 for local anesthesia or go ahead and continue probably treatments which she may not require local anesthesia. For scaling or filling, probably she may not require. But if she requires local anesthesia, I will take it to that level, then bring back. But come home is always plane 2. What she is trying to see is ask her if she has numbness on the other side of the lip.
इथे जडजड वाटते का तुला उठांना? हो.
Oh. आकर बेटा, बड़ा मुख लो. दर्द हुआ?
नहीं.
आकर. दर्द हुआ?
थोड़ा सा.
हुआ. आकर. वेरी गुड. अभी हुआ?
नहीं.
नहीं. अभी मैजिक करने का है मैं. आकर. मैं दांत निकाला कि नहीं आपका?
दात काढलं का मनस्वी?
शुड आई रिमूव द टूथ? निकालना कि नहीं? थोड़ा दर्द होगा. परवाह नहीं?
नहीं हो.
अभी निकालने का है. अगर दर्द हुआ तो परवाह नहीं? हाँ? क्या है? हाँ? अभी मैजिक करते देखो. अब्रकदब्रा 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 बूम 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 बूम. क्या है ये?
दांत.
ऐसा किधर जंप करके बाहर आ गया? हाँ? ये कैसे गिर गया? आपका ही है ना? कैसे निकल गया? पता नहीं. अरे कैसे जंप होके बाहर चले गए? देखो, मैं कुछ किया? मैजिक तो किया कि नहीं? देखो, मैजिक से दांत निकालते हम. आपका है ना दांत? अभी देखो उधर दांत है क्या, देखो ऐसा उंगली से, मीन जबान से, पुट योर टंग एंड सी. नहीं है? अरे हाँ करो, क्लोज, जोर से. वेरी गुड. नाउ यू आर गोइंग टू डू इट टू 0%. Down, down, down. 0, 0. More. Now for nitrous oxide, you end nitrous oxide with 100% because you are going to flush the lungs with the fresh oxygen. There is something called diffusion hypoxia. When nitrous oxide is being reversed, nitrous oxide will come out of the body so fast that it will throw away even the oxygen molecules. There will be a transient period of time where the lungs will be lack of oxygen. So this is called diffusion hypoxia. To counter diffusion hypoxia, you supply more amount of oxygen so that you fill the lungs with oxygen. Though diffusion hypoxia is not demonstrated in nitrous oxide sedation, but it is usually seen in anesthesiology circuits. Why? Because she could be sometimes breathing through the mouth when she is speaking. So all these things will not let her empty the lungs completely. The room air sometimes will enter and compensate for the diffusion hypoxia. So by rule, you end nitrous oxide with 100% all the time. So start nitrous oxide 100%, gradually start 100% oxygen, increase or decrease to your need, finish the treatment, then 100% again for 3 to 5 minutes. So oxygen start with 3 to 5 minutes, go ahead and do the procedure, end the procedure 3 to 5 minutes. So I have given the local anesthesia to serve the purpose of the local anesthetic pain, then I went back to plane 2. Okay? If you have realized anything from what she said, now ask in your language in Marathi whether she felt any discomfort while I was giving SHOT.
तुला काही वेगळं वाटलं का, दुखण्यासारखं किंवा वेगळं काही वाटलं नाही?
Then how did your tooth come out?
काढताना
How did the tooth come out? Ask her.
मग दात कसं निघाला बाहेर? मॅजिकने?
मॅजिक
हैं?
मॅजिक झाली का?
वो भी नहीं है वो भी पता नहीं है. अभी देखो ये हॉस्पिटल में एक ऑफर चल रही है, एक दांत निकाला तो दूसरा दांत फ्री है. लेते ऑफर? फ्री. अगर एक चॉकलेट ले तो दूसरा चॉकलेट फ्री बोले तो लेते कि नहीं लेते? अरे एक ड्रेस लिया आप शॉप वाला और एक ड्रेस फ्री बोलते, लेते कि नहीं? आज
तुला जर दुकानात म्हणाले की एका चॉकलेटवर एक चॉकलेट फ्री आहे तर तू घेशील का? चॉकलेट आहे ना, घेशील ना? दात किडते.
ask her about the dress.
आणि
One dress, another dress free.
आणि एका ड्रेस घेतला आणि दुसरा पण ड्रेस त्यांनी फ्री दिला तर घेशील?
Yeah. Why?
नाही.
Why?
का बरं?
Why? क्यों नहीं लेते? अभी एक दांत लिया तो दूसरा दांत फ्री है, उसका चार्ज नहीं करते हम. हाँ? करना कि नहीं? डिशुम. You can take the nasal hood off.
आहे आपला
Good job. Give me high five. So हमारा ट्रीटमेंट को कितने स्टार्स देते हैं आउट ऑफ 5? 5 स्टार्स को कितने स्टार्स देते? 5? सारे 5? फुल 5? अरे कभी नहीं मिला 5 स्टार्स मेरे को. Thank you. Get up. Now what's the plan now? Should I demonstrate the machine and?
Just demonstrate.
Okay.
One adult patient is there, sir.
Okay.
She is using it 2 minutes. You can just show parts of the machine and the
Okay. This is a portable machine. Concept का portable machine. This has got cylinders inside. if you see that there are two cylinders here, the machine what we have on the top is doesn't have an enclosure like this. This is slightly more good to see, but functionally both the machines are same. And the machine basically is made up of parts, and they are made to stand, and that stand is going to be on the wheels, and those wheels are anti-static material. Those wheels are made up of anti-static material because in winters when you shake hands with somebody you get that static electricity. So in anesthesiology circuits we don't want that kind of static electricity, so that can even instigate fires. So for that reason the wheels which we use for all anesthesiology machines, they are always made with anti-static material. Had it been a machine which is fixed, then the whole of this part wouldn't be available, it need not be there, because the whole cylinders will be somewhere outside and you run the tubes on it, and those tubes are connected with that. So when you have a central unit where the gas banks and the gas cylinders are somewhere else, then we have only this part which is needed. This is called mixer head. Okay, and the inner part, this part is called yoke. The function of the yoke is only to hold the cylinders. We have two sets of cylinders. One set means one oxygen and one nitrous oxide. The second set means that's the reserve cylinders. If you see, the cylinders are color coded, the tubes are color coded, and all this is because you don't want any kind of misconnections to be given. You know that oxygen is white, nitrous oxide is blue. You only take them to that fixtures and fix them. You cannot interchange because they are very evident in terms of colors. This is called, these are basically meant for not giving misconnections in the anesthesiology circuits. Apart from that, you also have something called a regulator inside. The regulator is going to reduce the pressure of the cylinders to a usable level. Just like how you have cooking gas cylinders in your kitchens, and you have a regulator on top, and that regulator is going to step down the pressure of the cylinder's pressure and give it to a stage where you have a low amount of flow is going to be released outside. Similarly, the role of the regulators meant for the same purpose here. And now you have head here. The head is something which we learned by comparing with the bathroom tap, which has two controls, 1 and 2. This is to control the flow, and this is going to be measured by number of liters of water coming into the bucket or number of liters of gases which are released from the machine. And the other one is called mixer. This is going to proportionate the nitrous oxide to oxygen. And there is a third control here which is called oxygen flush. The oxygen flush is basically to release oxygen into the circuit when there is an event of hypoxia in the patient, which is very unlikely to happen in dental circuits, but it's a mandatory control which is meant to be there on every machine. The mixer has two tubes. The one is meant for, these are called flow tubes. One tube is colored white, which depicts the flow of oxygen through this tube. The second one is blue, which is going to depict the flow of nitrous oxide through that. Now, when we say we are going to fix number of liters of gases coming through that, you can see the oxygen flowing through. And once this is measured at 0% nitrous oxide, that means it is 100% oxygen here. That means oxygen is flowing at 6 liters. Now after you do this, look at the bag whether it is moving equally by inflating and deflating, which I am going to demonstrate a little later. That is called tidal volume. So once you fix the tidal volume, depending on what is the level of discomfort you are going to give, you are going to raise or decrease the amount of nitrous oxide. Okay. Now this is called reservoir bag. Reservoir bag is like it's going to reserve the gases for about 5 breaths. That means if I shut down the machine completely, the gases which are available in the bag will serve for about 5 to 6 inhalations. That's a reserved gas. That's a reserved gas. So when you have the reserved gas, and the bag will deflate and inflate equally, which is going to depict the respiratory movements. The respiratory movements are going to be realized by looking at the chest or looking at the back. These bags are having a capacity of about 3 liters. These are 3-liter bags. Ideally, all the sedation machines should have only 3-liter bags, not bigger or not smaller. And the next part of the machine is called delivery tubings, and before the delivery tubings, above the reservoir bag, there is something called automatic air inlet valve. This automatic air inlet valve basically will provide, okay, this machine, the dental sedation machines are basically meant to be working in this way. Whenever the machine depletes oxygen less than 30%, okay, the nitrous oxide automatically shuts down, so that you will not end up in a situation where you end up breathing only nitrous oxide without oxygen. So by default, all the nitrous oxide sedation machines, when you deplete oxygen less than 30%, nitrous is automatically cut. Now when both oxygen and nitrous oxide are cut off, how will the patient breathe? So there is something called automatic air inlet valve. This is going to allow the room air get into the circuit where the person is going to breathe room air. So practically and clinically, when you are in the midst of the procedure, when the gases are getting over, you will find the patient who is not experiencing any sedations. That means he is breathing room air. That should tell you to check whether the oxygen nitrous oxide are there enough in the cylinders or not. If the cylinders are getting over, you open the reserve cylinders which are at the back of the operating cylinders in the machine. So this way you will have a continuity of the flow. Now the delivery tubings are going to be connected through a nasal hood. This is called double layered scavenging nasal hoods, meaning I have the connections going into this, going and release the nitrous oxide and oxygen mixture into the blue chamber, and this blue chamber is going to be on the nose. I am going to inhale nitrous oxide and mixture of oxygen with it, and when I exhale, the gases are going to get into the upper chamber. So when I inhale, the gases which are coming from the machine will go to lower chamber. I am going to inhale. When I exhale, they will go to upper chamber. This upper chamber is connected to a scavenging solution. You have a vacuum scavenging vacuum suction down there. The scavenging vacuum suction is basically suck all the released nitrous oxide. Yeah, that's fine. Suck, yeah, that's a scavenging vacuum suction. Now, the purpose of the scavenging suction is to suck the nitrous oxide, whatever is released to the upper chamber, and it is going to release it outside your room. So that you don't end up breathing nitrous oxide which is going to be released into the room if you don't have scavenging nitrous scavenging hood. So the movement of the gases in this delivery tubings is a one-way directional movement. The gases come out of the machine, go into the lower chamber, get into my nose, into my lungs, and come out, get into the upper chamber and released into the vacuum, and it will be sucked to the vacuum and it will be released outside. So this is the flow of gases going on everywhere. So that's about the machine. To recapitulate, we have a standalone dental sedation machine with the cylinders inside. We have 2 sets of cylinders which are inside. You have a yoke. Yoke is something similar there. This is the slab like thing is called the yoke, and the yoke's purpose is to connect the cylinders, and cylinders are color coded. The nitrous oxide cylinders are blue and white cylinders are oxygen. Now another interesting thing here is that there is something called pin index safety system. The pin index safety system works on, there are 2 pins inside, and those 2 pins are different from oxygen to nitrous oxide, meaning that clearly will not let nitrous to be exchanged to oxygen, oxygen exchange to nitrous. So this will avoid the accidents where you inadvertently misconnect cylinders. Okay, if you see here, there are 2 holes here. These 2 holes are different in their distance between them, between nitrous oxide and oxygen. There are 2 corresponding pins in the machine. So that's why it's called pin index safety system. So the corresponding pins on the machine will be maintained the same distance so that they go only into this. By mistake, if you put nitrous oxide here, it doesn't go into the machine. So basically this is meant for the dentist who doesn't have any experience about the anesthesiology machines. Same time, it will not allow any misconnections to happen. So these are all the necessary safety features of any nitrous oxide sedation machines which are meant for the dentist. Had it been an anesthesiologist, they know everything about machines, they know how not to misconnect it. But as a dentist, I may not be very familiar about it. Thank you. And we have another lady who would probably needs, I don't know what treatment she might need. Yeah.
nitrous oxide.
Oh, oxygen ka bill le lo.
Oxygen cylinder को लेकर
Okay, if you see the distance between these two holes here, these two holes, these are a female part of it, the male part of it is in the machine. If you see the distance between these two holes, it is slightly larger than this. Corresponding pins also will be in the equidistant. So I cannot put this pins here and this pins here, so that you don't misconnect the cylinders. So you have a color coding, you have a pin index safety system, and if you look at the machine at the back, just turn it around. If you see the machine at the back, there is something else which is called diameter index safety system. If you see these two nuts here, these are quick fix nuts. There are two different diameters, not the width, the diameter. It is wider than this. So meaning this will not go here, this will not go here. So these are all the safety features built into this machine so that you inadvertently don't connect wrong cylinders. So we have color coded cylinders. We have a pin index safety system, we have color coded tubings, we have diameter index safety system. All these things will not allow the misconnections to happen so that you don't come across any kind of inadvertent accidental outcomes. So that's about the machine. I can cover it in much more details if you still have any more doubts when I am doing the your hands-on demonstration, which I am going to do little later after the lunch. Yeah, we also have couple of dials here which is going to give you measure of amount of gases which are available. You have one dial to measure oxygen, another dial to measure nitrous oxide. There is slight difference between how you read these dials, which I am going to explain little later when I am going to demonstrate the machine in the next further. Idea is to know how much of gases are left over in the machine when you actually start a procedure at the day. Okay, so we will go ahead and do the procedure, whatever we have to do. Where are you from?
I am a localite. I stay here.
Okay, but you are a Malayali. No, you are not a Malayali. 1 second. Can you just get up? Yeah, thank you. Where are you from?
Sir, I'm born and brought up in Dubai.
Oh. And you are not a Malayali?
No.
You said Dubai.
Yeah.
I've asked 2-3 questions. So
Yeah.
would you like-
I will try to finish that.
So first is, can we put the patient on plane 3 if we want to use the air rotor?
Yes. Yes. But you don't want to do the procedure in plane 2. You only use it to give local anesthesia. But when you have to do the aerotor, when you have to use it, that's for the procedure. At that point of time, since you already served the purpose of giving local anesthesia, you go back to plane 2.
Plane.
In plane 2, you can do the treatment any long time. But if you're going to do it in plane 3, you're actually hyper-sedating the patient for unnecessary reasons. And you are releasing gases which are not desirable.
So plane 2.
Plane 2 is go home for all the time.
Okay. So next question is, what should be the pressure of both the cylinders, and at what pressure decrease we should replace it?
Okay. I will address this little later.
Yes.
That's about specifically about the pressures in the cylinders and how do you see on the gauges on the meters. I will address that later.
And last one is, do disposable nasal masks also have a double scavenging system?
Yes, this blue part comes in disposable format and autoclavable format. This blue color indicates that they are autoclavable. Disposable ones you can dispose it, but it has a price to it. Each disposable nasal hood might cost you about 350 or 400 rupees. But to reduce the expenditure, you can give the nasal hoods to the patient, ask them to bring back next time. So they will stay there for a very long time unless you change the size of the nose in terms of growth. I will explain that later. बाद में explain कर.
Fine, sir. These 3 questions. Thank you, sir.
What do you do?
Sir, I'm an intern here.
Oh, you got caught now. Yeah, these are disposable nasal hoods, but these are single laid nasal scavenging nasal hoods, which I don't recommend. If you look at it, They are, open this. So if you if you look at this is double layered scavenging nasal hoods, but this has only one layer. Though it looks good and it is very low profile, the disadvantage with this is this should be used without the bag, number one. Number two, without the bag I will not know whether the person is breathing through the mouth or the nose. Number three, though this can calibrate the percentages of gases, this will give more control in terms of volumes. So typically the single layered nasal hoods will contribute to the occupational disadvantages. You end up supplying more amount of nitrous oxide than necessary, which is going to flow into your room, and that could be contributing to occupational disadvantages and environmental concerns. So when somebody presents this, that this is a good mask, don't take. So where did you do your dentistry?
I'm doing it there.
Oh, you're okay. Good. Have you heard of nitrous oxide? Good. You must have done your homework then. But did you spend whole sleepless night last night? So before I put the nasal hood, I open the flow to about 5 liters and fill the bag to half. I fill the bag to half and wait for at least 5 cycles of respiration. One inspiration and exhalation is 1 cycle. So I need to wait for 5 liters so that I know that she is breathing through the nose. If you look at the bag is deflating and inflating, which depicts her respiratory movements. If you see the ball is moved to about 6 liters. That number 6 written here, her tidal volume is 6 liters. There is no great rocket science here. You simply have to match the bag so that it deflates and inflates equally. There is no great science here. Once you fix the liters of flow, you don't have to readjust it later. So meaning you are going to write this on your file, and it's very unlikely that you will end up changing this liters. Next time you straight away put 6 liters. Let me know if you're uncomfortable at any point of time. So when I am doing the treatment under nitrous oxide, I will not be quite like this. My cartoon will be going there. He's going to be watching the cartoon. Somehow I try to divert the attention of the patient away from the sedation. Do whatever you want, but try to divert the attention away from that. Play some music, ask the patient to listen to one particular tune or listen to the lyric. Or when it is children, I will ask my assistant to play a game where whatever I do, child is expected to respond in terms of gestures. For example, if I tap her 3 times, they should be showing 3 times. Where are your parents? She is going to show how many tires your vehicle had. So 4 or 5 are. So this way, I am going to challenge them that I am going to randomly ask you something. You are going to tell me in gestures. And if you do everything right, you will get a gift at the end. You don't get, but that child. So that's way I am going to divert her attention away from it. Said that, don't make it so obvious that our attention is entirely what is going to happen next time. Okay, the point is to relax the patient. That should start with the behavior also. So, okay, what need to be done for that? Oh, just a lay. Oh, injections. You know how veterinarians will give shots? Have you heard? Have you seen that? Huh? They put that and they do like this. So you will feel little heavy-headedness.
Yes.
Okay, you will not have any problem.
Yes.
If you are afraid of some point of time, just raise your hand also. At some point of time, you feel as if you are losing control. Please don't worry about it.
Okay.
Okay? I keep telling people, you cannot kill somebody with nitrous oxide.
Yes.
Only way you to kill is to take the cylinder and hit them. You know that, isn't it? So you will not die, don't worry. So, as you grow up on the experience of the experience, you can even rapid induce till 20. Because 0 to 10, 10 to 20 doesn't do anything. So, you straight away can put you to 20. But I don't want you to put somebody to 40 or 50 now. So, from 20 you can still ramp up. Because there is hardly any changes you will notice between 0 to 20. So, plane 1 is simply a via media. What are your parents?
Sorry.
What are your parents?
My mom is a teacher.
Okay.
And my dad is a nurse.
Oh, I'm sorry. So, which branch you would want to get in?
Ortho.
Oh, ho. Have you got an ortho treatment done?
Not yet, but I have to.
So people they want to see the eye reflex in blinking, but actually because of the angle it is not appreciated.
Okay.
Because the food is interfering with the.
Yeah.
So where is it?
That's okay, that's okay. I explicitly don't mention that I want to show the eyes here. You are making her more conscious about it. The point is to divert the attention. Can somebody, which is your favorite song?
Anything.
Anything? Janaganamana?
It's okay.
Play some, some lyrical song so that I want her to listen to the lyrics and tell me the meaning later. She may pretend that she is listening, but she wouldn't be. It's okay, it's okay, it's okay, it's okay, it's okay. This is not laughing gas, this is the song which is making her. You can keep it here. Listen to the lyric. And I'm going to ask you meaning. Suddenly I will ask you one lyric, what is the meaning? Keep it. That's enough. Switch on the light. Switch on the light. What is that?
There's a nice tingling sensation in the legs.
Is it? Good.
Even my fingers and everything.
You would be feeling on your lip also.
Yeah, everything on my extremities, everything.
So I'm going.
Feels as if you're in a cloud.
Don't come down. Be on the cloud. Tell us what is the weather forecast tomorrow. Is it going to rain today?
We all truly hope that it rains here.
It will be a rain of participants, that's it. Overwhelming.
Yeah, open your mouth. Good job. Now listen to the lyric. Elelo. You have to tell me which movie this song is from. Think quick. It's almost coming to end. Got it? Did you get the movie?
No. If I knew, then I would have surely remembered. But I don't know.
Did they tell you that I'm going to pull out your molar? No? They didn't tell you, is it? Oh my God. Really, they didn't tell you?
I said consent really.
So there are few things which I should not have done. I was putting her into conversation and making her laugh. Laughing patient under nitrous oxide is actually going to throw out nitrous oxide. If she was simply laughing, a laughing patient is actually indicator of a hypersedated patient. The very name laughing gas was given. The very name of laughing gas was given when laughing gas, when nitrous oxide was used as a recreational purpose, long time ago. But in a clinical setup, don't be very happy if the patient starts laughing. A laughing patient's directly telling you that I am a hypersedated. Everybody would be laughing. But here there is a patient who is laughing, who is showing that they are hypersedated. Okay? This is something not many people would understand properly. No, they always expect people to laugh under nitrous oxide. No. They are throwing more amount of nitrous onto your face and they are hypersedated. So in whichever way, that's a disadvantage for nitrous oxide. So we have given her local anesthesia. You would not have seen her, I should have showed her toes, whether she flinches or anything. Now, how painful was the local shot which I gave you?
Not really.
Have you taken local anesthesia before?
Yeah, this was the first time.
Oh, Dil Mange More?
It was okay. It was
No.
not something like how patients tell me that it was bad or it pains or something like that. Obviously, I understood the taste, but it was after I closed my mouth. It was not something that I would feel like closing it immediately or something.
Okay. They may think that it is stage managed. It's not stage managed.
This is my first time on anything actually. So it's not.
Anyway, thank you very much for taking a shot for us. She has taken, usually people take shot in the arm for somebody. She's taken a shot in the mouth for somebody. Yeah, go ahead.
What is the maximum percentage of nitrous oxide we can give to a pediatric patient?
That depends on what is your need, number one. You need to look for the signs and symptoms rather than looking at Let us the maximum what you can give is 70%.
Not an answer.
But you may end up sometimes giving 70%, but realizing the effects are only depicting plane 2. So when you are giving highest amount of nitrous oxide, but you don't realize the equivalent amount of sedation being realized, that means there is a leak somewhere. For example, if the mask is like this, now look at the bag, it doesn't move. Look at the bag there, it doesn't move. Okay, that means you have, say if you are giving 70 there, she is actually breathing room air. That 70% is not getting in. Now I am going to put the nasal hood on. Keep looking at the bag. Now bag is a very important tool. Now try to open your mouth and breathe through your mouth, not with the nose. Look at the bag is not moving. So when you are simply, no, it's moving for the, you can switch off the fan. The bag is not moving, that means she is breathing. Now close your lips. So this should tell you the importance of the bag and not a machine without the bag. Bag is an invaluable tool to depict the respiration.
So
Okay.
How do we decide the volume, the flow?
By looking at, I will demonstrate that when I am doing it.
So, but for the other participants,
Yeah, I am going to demonstrate on them or on me so that they will decide how to fix the flow, because I need to inhale correctly and show them. I will do that when I am doing it.
so now
Yeah, now only. I'll do that.
How to select the size of nasal tube by doing any
There are only three sizes
maxillary
of,
surgical procedure?
yeah, upper maxillary surgery.
As in,
Yeah, that's an inherent disadvantage of inhalation sedation, because maxillary anterior area you cannot use nitrous oxide. You can use it till you give local anesthesia. But if it is posterior area, you will not have any problem. Most of the companies will make about 3 sizes of nasal hoods: large, small and medium. Yeah, large, small and medium. And as I said, it all depends on how big is the nose. You don't have to go by millimeters. It simply has to cover the nose without putting any pressure on the nose. For example, if this is the small nasal hood, I can make it fit on my nose, but when you look at there, it's only pressing my nose. But outside it looks very fit. It should sit on the skin, same way it should not impinge on the nostrils, so that the passage of air will not be difficult. Okay, so if it is only size based on the nose size and the skin contact, you will choose either largest or small or medium. What are the other questions?
What is the maximum volume a patient might need in gas volume?
Gas volume, it depends on the lung volume. Sometimes athletes will need the highest amount of flow. It can even go to 9, 10 also. Usually it is for children, it is 5 liters and less, adults 5 and up. Now I will show you how to decide the flow. You're done. You can get up. Thank you very much.
You are doing impacted surgery cases faster, then how will they be able to track the level first and then
No, you don't have to. Just like how you use a mouth mirror to look up, it's only a matter of getting used to. When you start doing your dental treatments in your clinical work, it will be very difficult for you to visualize upper second molar and look in the mirror and do the filling on top, but you'll get used to it. Similarly, you will get used to it of how to handle the tissues when the nasal hood is covering on the nose. I will show you how to decide the flow. Can I have a larger nasal hood? ये नया मास्क है लास्ट टाइम याद है डू यू रिमेंबर लास्ट टाइम Now, as I said, first step in nitrous oxide inhalation sedation is number 1, treatment planning, number 2, behavioral assessment, number 3 is a medical history, number 4 is drug history, number 5 is respiratory diagnosis. Respiratory diagnosis, nasal breathing or mouth breathing is what we need to look at. Pulse oximeter will tell whether the transfer of the gases is happening or not. Once this is done, then you pick up the nasal hood, make sure that it is put on the nose. Okay, it simply have to cover all the nose without putting pressure on the nose. Make sure that it doesn't have leaks, and all the time the nasal hood should, the delivery tubing should rest bilaterally symmetrical, not like this, not like this, or like this. Okay, before I put the nasal hood on, I am going to fill the bag with oxygen. Make sure that it is showing 0% nitrous oxide, and put the flow to 5 liters. Put the flow to 5 liters or 6 liters also okay. Yeah. Now gas is flowing through 6 liters. Now at this point of time, I am going to put the nasal hood on, and I am going to look at 5 cycles. Is 1 cycle. 1 inhalation, exhalation, 1 cycle. You look at 5 cycles to know the trend, whether the bag is slowly becoming smaller or slowly becoming bigger. Now you will have 3 situations here. So if gases are flowing 6 liters, if the bag is deflating and inflating equally, that means those 6 liters equivalent to my 6 liters of tidal volume. That means my tidal volume is 6 liters. What do you look for? I need to look for the bag which is deflating and inflating equally. Okay. Now there is a second situation which is not a desirable situation. That means my bucket is getting empty. What do? I increase the flow. I can also ask the patient to use water slowly. That means it's equivalent to asking the patient to breathe slowly. I cannot control somebody else's breath. So instead of controlling my breath, I'm going to control the amount of liters of water coming into the bucket. So that is deflating bag. That means the flow is not matching enough to my tidal volume. The third situation is the bag is becoming big. That means the bucket is getting filled and the water is going to overflow. The overflowing could be oxygen or combination of oxygen and nitrous oxide. And when it is nitrous oxide, you need to be doubly careful because it's going to contribute to your occupational disadvantages. Plus, it's a wastage of gases. So I just have to reduce the amount of water flowing into the bucket. Reduce the flow by about a liter, then look for again 5 liters. Okay. So this is fixing of the flow. Then you realize plane 1, plane 2, plane 3. Our objective is to put the person to plane 2. From there, depending on what is the purpose, you need to decide whether to go to plane 3 or stage 2. Once you finish the purpose, then come back. So for example, if you have to give inferior alveolar block, so I expect the patient to be in plane 3. Okay, 1 minute, 1 minute, 1 minute, 30%, 40, 50, 3 minutes, 3 minutes. So after 3 plus 9, so I have a patient in plane 3. Give the local, then come back to plane 2. You are involuntarily, you should reduce the nitrous to plane 2. It should be like a involuntary reaction. Because our objective of using nitrous oxide is to provide anxiolysis, not to make the person stoned or knocked off. Though the name sedation is it's actually miscommunicating. Sedation by layman's term is to make somebody sleep, but we don't want a sleeping patient. It's like the term conscious sedation. I want to sedate, but I still want to retain little bit of consciousness. So minimal and moderate sedation are more appropriate terms than conscious sedation. Okay? Any doubts still here? Ask them if they have any doubts. If you have any doubts, just put it in the message box.
Brain flu also has a range, 25 to 40.
Yeah, it can happen anywhere. Look at the signs and symptoms. Extremely uncooperative patient will not be able to hold the nasal hood down. You need to have a little bit of cooperation for nitrous oxide to work. You know, it's quite normal to think with that much of cooperation I would have done everything without sedation. That's also another question. The idea is to provide that comfort, not what you can do, what patient need to experience. I can give injection, but is patient emotionally ready for injection? That is what nitrous oxide is going to be used to make the patient emotionally involved, emotionally cope up with that pain of stress of getting injection. For me, injection is poking tissue, that's all. That hardly matters because I don't feel the pain. My pulse is not going up, it is the patient. So, I keep telling people, you should respect the fear. You should respect the fear. Only respect the fear will know how not to instigate the fear. Otherwise, we will take things for granted. We lose that empathy.
There is a question, how can we understand how much gas is remaining in the cylinder?
By again looking at the okay, there is a difference between the gas levels of oxygen cylinder and nitrous oxide. Now oxygen gauge will show starting from 2000 psi, and like your fuel tank, it slowly comes down as the gas depletes. It's zero. Whereas nitrous oxide is liquid, and the top part of the liquid column is the column of vapor. So vapor, depending on whether it's this big or this big, it always consistently shows 750 psi till the gas reduces less than 1/5 of it. Meaning, if you start the nitrous oxide from the full cylinder, it will show 750 psi, and half it will show still 750 psi, 1/4 still 750 psi, 1/5 then it will start dropping from 750 to down. Okay, that's because you are measuring the pressure of the vapor. Vapor tall this long will remain the same. So depending on that, you will decide how much of gas is left over. Oxygen, you will know realistically how much is using. If nitrous oxide is showing 750, either it could be a full cylinder or just short of 1/5 of it. So once it starts going down, you know that it will be enough for just 1 or 2 patients going for it. Yeah, if you can see those gauges, वो मशीन निकालो, ओके इसमें निकाल, ओके इसमें you can show the gauges. If you see nitrous oxide, it's showing 750 psi. It will consistently show that. Anything else?
Bag needs to be changed for every patient.
No. Bag need not be changed because they have a lifespan. They last for about 6 to 8 months time. So you have to, otherwise they will break. You don't have to change between patients to. Okay, now this is non-rebreathing circuit. That means gases are going to go through only one direction. They are not going to reverse flow. So if at all you want to autoclave, this is the part you have to autoclave. Okay, rest all the one-way directional movement. But you can also autoclave the whole delivery tubings. Whole of this white part, which is called delivery tubing, you can autoclave it. But that's not necessary. Any other doubts do they have? Must be feeling hungry there. They must be cursing me. When is this guy going to stop?
So that is like conscious sedation is also used for like very anxious patients or uncooperative patients to immediately give.
Yeah,
40
sometimes if you are experienced enough, you can use it at the rapid titration. You can quickly sedate them, stone them at 50, then bring it down. But you should have little experience with the conventional ramping up. Then you will understand how to do that.
So after 30 and 40 we can directly go to 10 and 0.
No, you don't have to ramp down. Directly from, for example, if you're using 50, to reach 50, you increase the stents gradually. But when you're coming down from there straight away, give 0% nitrous oxide, that means 100% oxygen. When you do that, you are going to do about 5 to 6 breaths. In that 5 to 6 breaths, slowly nitrous is going to be coming out. That itself is ramping down. Though you reduce nitrous from 50 to 0, the nitrous do not come out of body in that speed. It takes about 5-6 breaths for it to come out. So body itself will ramp down. I think are we going to break for lunch or something? Then we'll assemble back. Yeah, no problem.